I'm going to talk about expanding applications for shockwave, and I said it earlier. These are my disclosures. I said it earlier. There's never been a time when vascular calcium is a bigger problem than it is right now, and I think it would be naive to think that calcium is not generalized in its distribution through the arterial tree, as shown on this cartoon, and it would be naive to think that calcium wouldn't be modified by IVL, and that IVL could provide benefit across multiple circulations. And I think that's what you're going to see over time, is the expanding application across multiple circulations for this technology. A little later, I'm going to briefly touch on the direct application of IVL to aortic valve leaflets in calcific AS. This is aortic leaflet restoration, or TAVL, as in lithotripsy, an experimental application of the technology. I said earlier, there's never been a time when large bore catheter access is more important than right now. And whether it's EVAR, TVAR, TAVR, mechanical cardiac support, the go-to access, frankly, has been femoral, TF. Unfortunately, up to 50% of iliacs and femorals have moderate to severe calcium. It can preclude such access. If you look below the knee, and we saw a great case of PVD, CLI, up to 75% of these vessels are graded as having moderate to severe calcium. Over half these patients have diabetes. And in the coronary space, up to 25, even 30% in some reports are graded as having moderate to severe calcium. I think it's clear that the widespread distribution of calcium in the arterial tree will drive the expanding application of IVL across multiple circulations over time. Its application in PAD, I think, has gone through multiple clinical trials, several of which are complete. Disrupt PAD 1, PAD 2, and Disrupt BTK. These are small trials. They're completed. They have a similar 3-component observation for standalone IVL that we'll come back to in a second. PAD 3 randomized is ongoing. It's enrolling. It's 400 patients with SFA popliteal disease, randomized to either IVL with a drug-coated balloon or PTA with a drug-coated balloon. My bet is going to be on IVL for reasons that you'll hear in a second. And then PAD 3 observational study is a single-arm, non-randomized registry. It'll be 1,000 real-world all-comers that'll be enrolled, and there's well over 200 patients enrolled to date. This slide summarizes Disrupt PAD 1 and 2 combined on the left, 95 total patients, BTK on the right, 20 patients. And you can see that 100% of the arteries treated here have moderate to severe calcification. The classic triad observation that you're going to see with standalone IVL is high acute gain, low residual stenosis, and a low incidence of complications, despite the fact that these are severely calcified target lesions. And these observations are obtained because IVL provides a marked increase in transmural vessel compliance through calcium modification. It provides a marked reduction in fibroelastic recoil. Remember that, that's an important contributor to its mechanism of action. And it obviates the need for high-pressure balloon inflation. When you can get full balloon inflation at low pressure, you mitigate the impact of barotrauma, which is complex dissection, rupture, perforation, and that's exactly what you see in these trials. I have a saying that get used to 0% complication for many of these, and it's maybe not 0 up to 1%, but you're going to see that phenomenon again and again when it comes to complex dissection, perforation, rupture. Look at the MLD, or the residual stenosis, and this is standalone IVL in heavily calcified vessels. It's got a residual stenosis of well under 30%, almost stent-like. The clinical outcomes at 30 days and 1 year are exemplary, and I think reflect the fact that these patients have a stent-like MLD when they go out. Well, TF access is the access of choice. It's the best access. We all know that, whether it was EVAR, TVAR, you saw TAVR, and mechanical cardiac support, a couple of those cases. It has lower rates of adverse periprocedural events following TAVR, lower rates of stroke and death. And we know that alternative access in general has a higher rate of complications and a higher cost. Our go-to alternative access at our center has been axillary subclavian, largely through surgical cut-down. We have a tremendous experience with this, but even in our hands, it's more general anesthesia, more resource consumption. Transcarotid, I think, and that was raised here a couple times, at least for the TAVR case. We've done a dozen of these. It's an excellent direct access, but it's general anesthesia, more resource consumptive. And how many of you in the audience do transcaval? I'd be interested in just seeing. Yeah, hugely resource consumptive, learning curve. And I think it's an extreme workaround, a problem that needs a more simple solution. I will go out on a limb and say I believe that at least 7 or 8 out of 10 TF access failures can be converted to success with IVL. You saw a couple examples here today with the cases. This was our first case well over a year ago. 85-year-old lady set up for TAVR. This is her CTA. You can see her right iliac has an arc of calcium over 270 degrees. There's near circumferential calcium in the abdominal aorta. But these lumen dimensions here really should have allowed passage of an Evolut Pro 26 millimeter valve. Absolutely. But you guys know it's not always about lumen dimensions. It's about compliance and tortuosity as well. And it didn't. This is when I met the lady. I was in an adjacent lab. My partners, Joe Chewy and Serenbach, have a safari wire in the apex. This is a dilator because they cannot get the 26 millimeter valve across that aortoiliac junction. And so we got looking at this little old lady. They asked me to come over and looking around, and we're saying we're going to cut her down from the axillary. And fortunately, our Shockwave rep, Jesse Halsey, was in the hospital. And he said, let's give Shockwave a shot, or as I say, give it a shock. I couldn't pass that up. So put a 14 wire adjacent to the safari wire. This is the 7x60 balloon in the iliac and then in the aortoiliac junction. Traded the wire out for a D15 because, as you know, the Medtronic devices, despite the nose cone iterations, frankly track a D15 a lot better than a safari through rough terrain. The case was closed after the procedure, home the next day, and I'm not making this up, granddaughter's wedding within a week. You know, this story could have been different for a frail 85-year-old lady with an alternative access. Here's 42 consecutive cases of IVL-facilitated TAVR access published by Carlo DiMario and Jack CI. 91% percutaneous, 80% the common iliac was the target. The arc of calcium in the iliac averaged about 270 degrees. And the go-to balloon here for this application 85% of the time is the 7x60. Transfemoral valve delivery was successful 100% of the time, and at the time of IVL, 100%. So it's a standalone single sitting procedure. About 80% had a 14 French device, and remember I said get used to zero perforation, 0 complex dissection, and 0 bailout stent. 93% of these patients were closed percutaneously with either perclose and or angioseal. This is probably the most explosive area of use, I think, with the advent and development of chip centers around the country. This was our first case published by Robert Riley in our group, and it's in CCI. These videos are in CCI. Look very carefully. This is a Impella CP 14 French without the peel-away sheath, and this is going absolutely nowhere. This is the 7x60 balloon. You look at the density of calcium on both sides. And then look, this is real time. As you saw before, nothing changes the transmural compliance of a vessel like this. You know, in structural, we'll shift these aortas halfway into another zip code at times. And this was easy. We had 13 cases. It's a registry, and that registry has been submitted for publication by Robert Riley. And I can tell you that there is 0 perforation, 1 stent, no surgical exploration. All of them were closed percutaneously. And it's a phenomenal experience of facilitated access for Impella mechanical cardiac support as well. So I think there's no question that Shockwave will facilitate large bore catheter access. And keep in mind, it changes transmural compliance. It almost eliminates fibroelastic recoil, which is very important. And the incidence of complications, at least in our experience to date, both in the periphery and in the coronaries, has been extremely low.